Thank you so much, Dr. Sethi, for conducting this wonderful course. And I'd like to acknowledge the support of my colleagues, Dr. Deepa Agrawal and Dr. Vaishali, in making this presentation. We do receive research grant support from Alcon Laboratories. So, primary posterior capsular axis is all. Oops, sorry.
Yeah, perfect.
So primary posterior capsular axis is actually kind of a part and parcel of pediatric cataract surgery. But why is actually primary posterior capsular axis necessary? And we published this way back in 2011, a review on PC posterior capsule management. And in the article, what we found was that if you have an intact capsule, you'll probably have almost, like Dr. Jethani said, more than 80 to 90% chance of PCO, which is visual axis obscuration in children. Only PCCC will have a high visual axis obscuration rate of about 36%, and along with vitrectomy, it goes down to about 11%. So about 1/8 of what you do only with without any posterior capsular axis, you will get with posterior capsular axis with vitrectomy. So a significant drop. Now, how do we do posterior capsular axis? Is that we are very worried that the moment you touch the posterior capsule, you are going to cause vitreous phase disturbance. And the reason why that occurs is that we typically use our bent cystotome to puncture it, and sometimes you need a little force to puncture it, and that's how the anterior vitreous phase gets disturbed. So therefore, what we find useful is to turn the cystotome tip sideways. So we are actually, it's like a cloth, you hold it and you kind of hook it, and you hook it and pull it up rather than puncturing it in, so that you don't actually puncture and try and hit the anterior vitreous phase. So this is what we are trying to show in the animation, that if you and the second thing, after creating that punch, where do you inject the viscoelastic? So Dr. Marie Jose Tesignong shows beautiful videos of injecting cohesive viscoelastic below the through the actually posterior capsular opening to push this anterior vitreous phase back. I would be a little cautious in doing that, particularly with a very cohesive viscoelastic, because sometimes by doing that, you actually tent up the rest of the posterior capsule very much up, and that causes a lot of posterior pressure, which can sometimes lead to a uncontrolled tear of the posterior capsule. So therefore, I think it's best to kind of inject it on both sides of the tear or the puncture that you have created, rather than through the hole. That will allow you a good control. So this is what I mean. This is the puncture, and we are injecting all around, surrounding the posterior capsular puncture that is created, so that actually that part becomes concave, and when you try and grab it through this, you don't actually end up with a very forwardly bulged posterior capsule. So this is to show we have created the puncture by lifting it up, and once that is done, I think here the role of micro incision capsular axis forceps is of paramount importance. As you can notice, we have just made 3 1 mm side port incisions. We have not made any main port incision, because that's the only time you're going to need the main port is during IOL implantation. So keep it as close as much as possible. And definitely this is the case where you would want to use a slightly heavier cohesive viscoelastic with no financial interest. Helon GV or Helon 5 is something that we prefer. Helon 5 for very young children or with intumescent cataracts, and Helon GV for rest of the children, and you can achieve a smallish central posterior capsular axis. Coming to vitrectomy, which is also an integral part of pediatric cataract surgery, the question is, how do you approach it, limbal or pars plana? Now the problem in children is, particularly growing children, is it's very difficult to find out what is the actual area of the pars plana or the pars plicata, and therefore typically limbal vitrectomy is a treatment of choice, and you have the maximum cut rate that your machine offers, with a very low flow rate of 10 to 12 cc per minute and a low bottle height and an appropriate vacuum of 250 to 300, and you do a top down, that is turning the face downwards, and when you come to the edges, just turn it sideways to make sure that the vitreous is removed even around the posterior capsular tear. Now there are options of doing the posterior capsular axis after IOL implantation, like Dr. Jethani had showed, and the easiest kind of way is to do a capsulectomy with a vitrector. So this is the case that we start off with. This is what we have ended up with. Now we place the IOL in the bag, and then what we do is we kind of go suture the main wound, make a trocar, and along with the vitrector with very controlled action, because vitrector axis can split very quickly. So don't keep a very high vacuum and do the capsulectomy along with then use the same vitrector to do the vitrectomy. The only drawback of this is that quite often, particularly if the capsule is a little fibrotic, the chances of split are very high, and then if you have a single piece IOL in the bag, it becomes very messy to handle that. Another option is to do the even the PCCC with forceps and through the pars pliccata, which we published in 2011. This is something that we attempted and we did for a while. It's not something that we would recommend very often, for the simple reason that you may end up disturbing the vitreous when you are moving with the forceps. It does cause significant traction. Now coming to optic capture, something that is very close to our heart. So optic capture was described way back in 1994 by Dr. Howard Gimbel, and he showed significant beautiful outcomes of clear visual axis after optic capture. In fact, we published an article few years later showing how it is not useful and it causes a lot of inflammation and lot of visual axis obscuration. But that's probably because our lack of understanding of the surgical technique as well as the materials of the IOLs that we were using at that point of time. So optic capture is something that we use primarily in congenital cataract, but also in traumatic cataracts, like Dr. Nishal was describing in after the first talk. The principle of optic capture is to fix the lens, and to fix the lens it does two things. One is the lens is not going to move, it's going to stay behind, way far behind from the iris, and the second is it kind of locks the epithelial cells, not as probably effectively as the bag in the lens, but a similar principle that will make sure that because of the capture the lens epithelial cells don't migrate to the center. So it gives a tremendous superior stability, and this is my colleague Dr. Samresh who made this wonderful animation that when you have in the bag IOL implantation, there is that space in which the IOL can move, can shift over a period of time. But when it is locked, like in an optic capture, where it is fixed, no matter what happens, whatever the growth of the eye, whatever happens, the position of the IOL is not going to change. So I think definitely as far as stability goes, it's far more superior. And as far as visual axis obscuration goes, because of this optic capture, the anterior and the posterior capsular axis fuse around the haptics. So the lens epithelial cells have a very little chance of actually going behind the IOL on the anterior vitreous phase and causing visual axis obscuration. So this is what we mean by a posterior optic capture, that once after the cataract surgery is done, we go ahead and do a posterior capsular axis. Then we have placed now the 3-piece IOL in the capsular bag at the moment. So this is the anterior capsular axis and this is the posterior capsular axis. And once that is done, you go ahead with a Lester hook or whatever instrument of your choice and actually move from one half to the other. So you do one half, push it in, punch it in, and you'll see this dumbbell shape that is coming up, and same thing you repeat on the other side. And this is the kind of ideal situation that you'd want. This is suggestive of a good optic capture, and these are cases 8-10 years down the line as well. And we published this with the research grant support from American Academy, ASCRS, American Society of Cataract and Refractive Surgery, comparing in the bag IOL implantation with vitrectomy and only optic capture without vitrectomy, and we found that the outcomes were very similar in terms of visual axis obscuration, inflammation, and as far as glaucoma goes. So we find that if we are able to do a good posterior capsular axis, optic capture is something that we prefer, because it allows us the advantages of capture and allows us to avoid vitrectomy in children, because none of us actually know the role of vitreous in a growing eye, how it's going to affect the growth and other things. So if we can avoid something, it's always good. So I'd like to end my talk at this point of time. Thank you.